Welcome, everyone. Welcome to our Newborn Toolkit and Path webinar, Lactation and Breastfeeding Support for Small&Sick Newborns and Their Mothers, Creating Sustainable Systems Change. Happy World Breastfeeding Week. Today's webinar is a very, very special webinar in collaboration with the amazing Path team. And this year's theme is Prioritizing Breastfeeding, Create Sustainable Systems Change. My name is Dr. Mbozo Sipalo. I'm the co-lead, knowledge management co-lead of the Newborn Toolkit. And this webinar will be translated to French. So at the bottom of your screen, you should see a globe where you can switch to French if you need to. We're thrilled to have you here for yet another exciting webinar. Please introduce yourself in the chat. So today promises to be a dynamic and interesting webinar where we'll learn about all things breastfeeding. And once again, today's topic is lactation and breastfeeding support for small&sick newborns and their mothers, creating sustainable systems change. Our webinar series is structured around the 10 core components of small&sick newborn care based on the WHO and UNICEF guidelines. And this is our implementation learning seminar series where we move faster together for small&sick newborn care. So join the Newborn Toolkit to hear about webinars, news, to share tools and ideas. On your screen now, you see our toolkit cog, where we have different health system building blocks, again, linked to the WHO UNICEF core components. And you also see QR codes to our newsletter in English, French, and you can also follow us on Blue Sky, Twitter, LinkedIn, and Facebook. So just to flag our upcoming webinars, on 9th September, linked to World Sepsis Day, we'll have a webinar titled Babies and Bugs in Hospitals, Time to Act on Infections and AMR. And on 21st October, we'll have a finance webinar where we'll talk about the global cuts and what small&sick newborn care can do in this challenging climate. Welcome. Please introduce yourself in the chat. And now I'll hand over to my amazing colleague, Lauren. Lauren, over to you.
Thanks, Mbozo. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez le bouton de traduction affiché sur le menu de Zoom. On a aussi quelques webinaires à venir. Le 9 septembre, les bébés et les microbes dans les hôpitaux, il est temps d'agir contre les infections et la résistance aux antimicrobiennes. Et le 21 octobre, le webinaire sur la finance. Alors, nous vous invitons à nous rejoindre pour ces webinaires et aussi pour vous introduire dans le chat en indiquant votre nom et où vous nous rejoindrez aujourd'hui. Merci. Next slide, please. Next slide, please. All right, you might be taking a little lag there, and we'll just get the slides back up in a moment. Perfect. So yes, just to introduce our host today, Kimberly Manson. So Kimberly is part of the Maternal and Newborn Nutrition Advisor with PATH, Maternal, Newborn, and Child Health and Nutrition Program. She's a trained registered dietitian, nutritionist, having experience with clinically and in the global health field. And we were very excited to welcome her here today as our host for the webinar. So without further ado, I will hand over to Kimberly to take it from here. Thanks.
Great. Thank you, Lauren. Happy World Breastfeeding Week, everyone. We know that the first week of August is always dedicated globally to focusing on the first food system. So what it takes to give the best nutrition to our newborns and beyond, that setting up success for early nutrition. So it's something that is very, very close to my heart. And today we're thrilled to be partnering with the Nest Toolkit team, specifically to focus on the experience of what it takes for systems for the vulnerable newborns to support breastfeeding when it doesn't go perfectly. What does it truly take to make it, to help a system strengthening approach to support that? So throughout the webinar today, you will hear from mothers, you'll hear from support systems, policymakers, guidelines, all different topics related specifically to this population. And so we're starting with a peer support network system. And I'd like to introduce our first speakers. We have Mrs. Gayatri Verma. She's a proud mother of Anadi, who's now 2 years old, 9.8 kilograms, and full of life. She was born too soon on 17th March 2023, weighing just 970 grams. She benefited from peer-to-peer support while Mrs. Gayatri's nursed her preemie baby. We also have another speaker along with her showcasing this story of Dr. Shweta Sharma. She's a senior physiotherapist at Dr. RML Hospital in New Delhi with over 18 years of experience, a gold medalist in BPT and MPT in cardiopulmonary physiotherapy, and she's certified in Mulligan, celiacs, and pulmonary rehabilitation. Dr. Sharma has received multiple awards, including the Bharat Gaurav Puraskar and Shakti of Physios Award. She's a panelist on AIR and Doordarshan. She actively promotes physiotherapy awareness. She serves as coordinator, is on academic committees, and has published in reputable journals. Dr. Sharma is also a regular speaker, examiner, and resource person at both national and international conferences. So I hand it over to both of you. Thank you.
Everyone, today with this video, I'll be sharing story of two devoted mothers and would like to throw light on the unique practice of encouraging parents' engagement and nurturing care that we are doing at our hospital. This practice ensures that the child grows up in a safe, supportive, and loving environment, which promotes emotional security, cognitive growth, and resilience. Involving families in the care and decision-making strengthens bonding and encourages responsiveness parenting, laying a strong foundation of lifelong well-being of a child. Today, we have with us a very special guest, Gayatri, a devoted and resilient mother who had a challenging yet inspiring journey with her child who struggled with being underweight after the emergency C-section. Watching the child's health issues, especially around the nutrition and growth, can be emotionally and physically exhausting for a mother. But through persistent learning, guidance of this unique practice, Gayatri has navigated her path with strength and grace. We're honored to have her today to share her story. Welcome, Gayatri.
Hello everyone, I am Gayatri Verma, proud mother of Anadi Verma, born on 17 March 2023, weighing just 970 grams. Her early arrival led to an emergency C-section and she was taken to the NICU before I could even hold her. Seeing her tiny, fragile body broke me. I was filled with fear and guilt, but I was not alone. The incredible team at RML Hospital is involved in the practice of immediate feel of parents being with the baby. Such unique practice will help in baby's overall development. They taught me how to care for her. I learned everything from tube feeding to Kangaroo Mother Care. This improved my confidence and it was so soothing and great experience. I almost felt that the baby is experiencing the same as she would have got inside the womb. Because of such unique practice and effort, I grew stronger emotionally and mentally. Being included in every step made all the difference. It was not just a medical care, it was emotional support, empowerment, and love. Today, my daughter Anadi is 2 years old, 9.8 kg, and she's full of life. She's a little warrior, and our journey, though filled with challenges, struggles, sleepless nights, emotional breakdowns, and prayers. But I faced it boldly, and it made me realize the true strength of a mother. My message to all the mothers: you are stronger than you know. A mother is truly another form of God. Thank you.
Myself, Dr. Shweta Sharma. I feel grateful for the chance to share my journey as a mother as well of beautiful 3 children, all born through cesarean section, 2 in the private hospital and 1 younger one in the central government hospital. I want to express my heartfelt thanks to the RML hospital where my younger one was born. As a mother, exhausted in pain and full of uncertainty, I will never forget the support I received from the lactation team at RML. Their guidance gave me the confidence to begin breastfeeding. They patiently explained how it strengthens a baby's immunity and build a powerful emotional connection between the mother and the child. Even when it is very challenging, their encouragement kept me going. From doctors to the nurses, they took care that the baby's sleep was protected. Baby was handled very gently, and they encouraged me to get involved directly in her care. I had a freedom to get indulged in all the activities of the baby care. Therefore, it really gave me skills and confidence. The entire team was compassionate and professional. We as a parent were encouraged to be actively involved in our baby's care, from breastfeeding support to the emotional bonding. This unique program helped me feeling less anxious, strengthened my connection with the baby, and contributed to her faster recovery. Not every journey is perfect, but it's mine, and I'm proud of it. It gave me immense pleasure if I, with a message of any one mother, feeling less and alone, more confident, then sharing it is worth it. Thank you. Everyone.
Well, thank you for that. And thank you to our speakers who are also on this call just for preparing that video. I think for those that are just joining us, we're jumping right into our webinar for World Breastfeeding Week. We are going over from all different stories and perspectives for what does it take to support systems to support the most vulnerable of newborns in their breastfeeding journey. And we just heard from a peer support system, but also from the experience of a mother stating how strong mothers can be. And it's an internal strength that comes out. And that was an incredible story. So thank you to Ms. Gayatri Verma for sharing your personal story of your journey with your baby. We will now move to a different level and perspective for an overview talk of our standards. So where are we at policy-wise? I'll be inviting Dr. Lawrence Grummer-Strawn from the WHO Nutrition and Food Safety Team, and let me introduce his background. Dr. Larry Grummer-Strawn is the unit head of the Food and Nutrition Actions and Health Systems Unit at the WHO. He coordinates the WHO's work on infant and young child nutrition, acute malnutrition, micronutrients, and overweight. Having previously earned his PhD from Princeton, he served as chief of the nutrition branch at the U.S. Centers for Disease Control and Prevention until 2014. He's an epidemiologist who has published over 180 scientific publications. He's recognized internationally for his work on vitamin and mineral deficiencies, breastfeeding policy, and development of both the CDC and WHO growth charts. He leads the Baby Friendly Hospital Initiative, the Code of Marketing of Breast Milk Substitutes, and the Global Breastfeeding Collective, as well as the Global Complementary Feeding Collective. So welcome, Dr. Larry Grummer-Strawn. Thank you.
Thank you, Kimberly. Good morning, good afternoon, everyone. I'm happy to take a few minutes here to talk about some of WHO's perspectives on the optimal feeding of preterm and small, sick newborns. Next slide, please. Just to set some context for all of us, we know that human milk is incredibly important for small and sick newborns. To quote one of our documents, human milk is medicine for both the mother and the infant. For the infant, we know that it is incredibly important for the development of that very immature baby, helping to address issues of feeding intolerance, protecting against sepsis and enterocolitis. It helps with the development in protecting against retinopathy, lowers the risk of obesity, blood pressure, insulin resistance in those babies. And the mother herself also benefits, being protected from various diseases, breast and ovarian cancer with longer breastfeeding, type 2 diabetes, and certainly better for her mental health in caring for such a vulnerable baby. Next slide, please. So WHO has defined what we considers to be the optimal care of the preterm and low birth weight babies, with a section of our guidelines on this really dealing with the feeding issues. As might be expected, the first recommendation is that mother's own milk is the optimal feeding choice for all babies, including very low birth weight and very premature infants. When it's not available, the mother just has not produced enough milk yet, or is not yet coming to volume, or there are other difficulties with the mother's health, the baby can't suckle. In these cases, we also can turn to human milk still in protecting her with donor human milk. We don't generally recommend fortification, but it can be used in certain circumstances. And the mother's own milk and donor milk, when they're not available, the third option that we would then turn to would be preterm formula. Next slide, please. They should start as early as possible. It's recognized that that isn't always as easy as possible as it is in full-term healthy infants. But that we really should be considering the options of scheduled feeding in these babies to make sure they are receiving enough. Kind of goes against our standard wisdom of the on-demand feeding for normal babies, because we actually need to make sure they're getting enough and they don't have the opportunity, they're not able to show those same signs of satiety and need for feeding. We also have recommendations for when we are using feeding methods alternative to feeding at the breast, such as gastric tube feeding or cup feeding, that we need to keep increasing those volumes over time because the needs of the babies will be growing. Next slide, please. So we have these recommendations of how the babies ought to be fed. The question is, how do we actually provide the kind of support to make that possible? And there have been numerous calls from WHO, including through various World Health Assembly resolutions. We have to do a better job providing skilled support for breastfeeding. It's not good enough to say we promote breastfeeding and, oh, mother, you ought to feed your baby with human milk. We actually have to provide that skilled support, make sure that we're building the systems and the capacities of our healthcare workers to really provide that kind of support. It's written into the global strategy for infant and young child feeding that has really been our standard for what's needed for breastfeeding for many, many years. And the Global Breastfeeding Collective has one of its top priorities to improve the access to skilled breastfeeding counseling as part of our support in health facilities. So we say this over and over again. Let's get into a little bit of what are some of the specifics of what that looks like. Next slide, please. For a long time, since 1991, WHO has supported the Baby Friendly Hospital Initiative with the 10 steps to successful breastfeeding. Traditionally, that was kind of thought of as only being relevant for healthy full-term newborns. And in 2018, when we revised the guidance on this, we really wanted to emphasize that no, the 10 steps really are for all babies. It does apply for small, sick, and preterm newborns as well as for full-term babies. However, there are sometimes situations in which we need to emphasize certain steps even more so than others. And there might be some ways that we need to deliver some of the 10 steps in different ways, depending on the conditions of the baby that we're caring for. So skin-to-skin care is particularly important. We've really emphasized the importance of immediate Kangaroo Mother Care, and as well as continued and Kangaroo Mother Care out into the community. And so this is a critical message that really needs to be built into our care. Early initiation may not be quite as early in these babies, depending on their health status and how stable they are, their ability to suckle. And so we want to be as early as possible, as that recommendation was there, but it might be a little bit later. If we do have to separate the mother and baby for various health reasons, it's still important that the mother have unrestricted access so that they can come and provide human milk to their own babies. There may have to be separation for actual care moments, but that doesn't mean that they should be housed separately from one another. And we really do want to emphasize Kangaroo Mother Care. Non-nutritive suckling actually is often beneficial for these babies. And so whereas for the normal full-term infant, we generally are saying nothing else should be going into the baby's mouth other than the breast. In this case, other kinds of oral stimulation may actually be valuable. And we really emphasize in here in step 10 that follow-up care is critically important for these babies. We cannot just assume that because we've fed them right in the first few days and gotten them started on breastfeeding, that all is going to go well. They're going to have challenges with feeding, and so we need much better ongoing care for them. Next slide, please. So we said this in the guidance in 2018 that they need to be part of the 10 steps. And so we wrote a clinical management guide to really go much deeper into in those units where we are really caring for those small and sick newborns. What are the special cases that they need to deal with? So in those neonatal wards, how do they actually manage these difficult situations? We know that the rates traditionally have been much, much slower. Rates of breastfeeding have been much lower for those babies. And this is for a variety of reasons. There are numerous challenges that we really have to face in those neonatal wards. It's often noisy and stressful to the babies. It's making it more difficult for them to feed. They're unstable physiologically. We have infection control measures to really protect them. And so sometimes that gets in the way of our normal care of how we would handle the baby and bring the mother to them. There are issues with delayed lactogenesis in a preterm mother. Issues of oral motor skills, suck-swallow discoordination difficulties. And oftentimes the healthcare staff are not adequately trained in how to actually support feeding at this time. And so we really have to address these 10 steps in a much more critical way and really figure out how do we adapt them. And that's what this clinical management guidance tries to do. It goes through step by step. I'm not going to go into the details within it, but it really goes through step by step. How do you care for different kinds of babies and how do you apply these 10 steps in those situations? Next slide, please. Putting this into a quality of care framework, WHO has really been emphasizing over the last 10 years, how do we actually improve quality of care across the board? And we have a standard set specifically for small and sick newborns. And it steps a little bit higher level than just the how do we provide the care, but actually how do we set ourselves up in a systemic way to make sure we are supporting them. So it calls for a policy that reflects the 10 steps to successful breastfeeding, including application of the Code of Marketing of Breast Milk Substitutes. It lays out standard operating procedures that are necessary for both exclusive breastfeeding and the optimal feeding, even in those situations where exclusive breastfeeding may not be possible at the breast. Talks about space for the mother to express her breast milk and how to support that mother in terms of her lactation, getting her up to volume. Mechanisms for maintaining lactation over time, even when the baby's not yet able to suckle at the breast, and how to monitor feeding difficulties that babies are having here. And again, emphasizes that staff training in both counseling and how to actually deal with the problems that the mothers are having with breastfeeding becomes a critical issue here. Staff training, as it is normally done in pre-service, where they get very little information, mostly about the importance of breastfeeding, but not in how to support it, is not going to be adequate. And we have to be looking at competency development for our staff, both in pre-service training and in in-service training. Next slide, please. Now, of course, we sometimes do have to go beyond the mother herself in supporting her. And so as was noted in the recommendations, when the mother herself is not able to supply enough milk to support her baby, we do turn to donor human milk banking as the next option there. And what that means is that we have to figure out how do we actually set up donor human milk banks. And WHO is in the late stages of developing a set of standards for how donor human milk banking ought to be managed. Goes through issues of how to recruit the donors, how to remunerate them, donor screening and education, how to store the milk, how to handle the milk, issues around pooling it, how it should be treated or pasteurized, and then once it has been treated, how to actually test that it actually is safe for the baby and ready to use. So it really kind of goes through this full process of how should donor human milk banks be set up for that management. I hope to have those standards out by the end of this year. Next slide, please. Finally, I want to mention another option that WHO has not been quite so clear on. Sometimes we do mention issues of how other mothers might be used to support the feeding of these babies when the mother herself is not able to. And so it is listed as an option in the context of COVID-19, HIV, wasting situations, emergencies where we might actually turn to another mother to feed these babies as an alternative option. UNICEF just recently put out some new guidance on how to support access through wet nursing, particularly in emergencies, but the concepts there also apply in other contexts about how to actually select an appropriate mother, how to manage a system that actually can provide that optimal care and is an alternative to donor human milk. It's an issue that we probably want to look more deeply into, but WHO hasn't gotten quite as deep there yet in understanding those. We really have three options to take care of our babies. So I just want to thank you very much for your attention and looking forward to the discussion later on with our various panelists to look at other aspects of how this care can be provided. Thank you.
Larry, that was a fantastic overview of all of the different standards, policies, related guidelines, guidance that is out there from World Health Organization, UNICEF, and beyond. Thank you to the hosts who have put both in English and French, wherever possible, links to all of those documents that Larry mentioned. These are fantastic resources for turning to understand the nuances of that really involved care, the more in-depth than just exclusive breastfeeding. What does it actually take to get there, especially for the smallest newborns? So thank you, Larry, for that overview. Very, very helpful. We're going to shift gears now on our next discussion, but before we do, just a reminder, please put any Q&A questions that you have, especially for our last speaker, Larry, from the WHO, in the Q&A section of the webinar. We will be getting to those at the end of this call. So thank you for that. So specifically, we wanted to turn to an experience from a pediatrician in Uganda. So thank you to Dr. Elizabeth Kiboneka, who we have. She's a senior pediatrician with vast experience in implementing nutrition and health programs in and out of Uganda. She has spent most of her career advocating for the integration of nutrition into the healthcare system. She has led numerous successful ventures, including the Nutrition Center of Excellence, known as Mwana Mugimu Nutrition Unit, located at Mulago National Referral Hospital. She is currently retired from civil service and now serves as a patron for the MAMI Uganda chapter, supporting the Ministry of Health and improving the care of infants less than 6 months and their mothers. So we wanted the perspective specifically from a MAMI as well as the nurturing care lens. So thank you. And Dr. Elizabeth Kiboneka, over to you.
Thank you very much, Kimberly. Happy World Breastfeeding Week to everybody on the call. The topic is nurturing care and lactation, optimizing support for mothers and small and sick newborns. Next slide. I will start by looking at a few definitions in the introduction. Nurturing care is care provided in a stable environment that is for children's health and nutritional needs, with protection from harm and opportunities for learning. Lactation is a process of milk production and secretion from the mammary glands, primarily in females, to nourish their young. When you're looking at small babies, these are categorized as small for gestation age. At birth, we are looking at less than 10th percentile for their gestation age. We're also looking at low birth weight, those babies who are born less than 2,500 grams at birth. And these are majorly preterms. The newborn period, these are infants in the first 28 days. Next slide. Looking at the situation analysis of newborns, globally newborns deaths account for 45% of all under 5 deaths. In sub-Saharan Africa, 1 million newborns die every year. 75% of these deaths are preventable. The small and sick newborns are the greatest risk of death and disability. Of the 2.3 million newborns that die each year, approximately 80% are low birth weight, and 2/3 of these are premature. Sustainable Development Goal 3.2, the global target for newborn survival, is to reduce neonatal deaths to 12% per 1,000 live births by 2030. Next slide. Approaches to support small sick newborns. The small and sick newborns require high-quality, country-led approach health facility and community services. The delivery of these interventions depend on having a functioning health system, including adequate infrastructure, human resource, equipment and commodities, and information systems to track progress. Some of these Dr. Strawn has highlighted. We therefore need to have the right space, the right people, and the right supplies backed by a supportive leadership and data for action. We need to have families at the center, ensuring zero separation between parents and their newborns. Next slide. Our country experience in Uganda. Nutrition care for small and sick newborns mainly focuses on protecting, promoting, and supporting exclusive breastfeeding. Provision of donor breast milk, which has just started, is very limited when needed, and ensuring adequate feeding even when the baby is sick. The care also includes resuscitation, thermal care using the Kangaroo Mother Care, recognizing danger signs, prevention of infection, and providing follow-up care after discharge. With continued monitoring and support, these are crucial to ensure that the baby's continued growth and development. Next slide. Next slide, please. Now, the major challenges. Yes, the challenges. The major challenges in managing the sick, the small and sick newborns. One, there's limited specialized lactation support for the newborns at health facility and community especially. There's also limited nutrition and health services. The access to specialized care and equipment like the neonatal intensive care units and the human milk banks is also limited. The follow-up care. There is a challenge with following up these newborns. There is therefore need to develop well-defined protocols for follow-up care after discharge from facilities. We mentioned the family-centered care. This has been a challenge. There is need to promote family-centered care where parents are actively involved in the newborn's care rather than just being passive recipients. And also the other big challenge is integration. WHO's quality of care standards for maternal, newborn, and child health, they need to be fully integrated into newborn care practices to ensure quality and consistency. Next slide. Next slide, please. So as we look at the future, we are aware that the mother's best gift for her newborn baby is breast milk. Hence, mothers require all the support throughout their breastfeeding journey, right from antenatal through to labor ward and postnatal until when the baby has gained sufficient weight. Countries need to further invest in breastfeeding to support child survival, health and development, and strengthen the national economies. The care for small and or sick newborn will require strengthening facility-based newborn care with strong community linkages. During this World Breastfeeding Week, it's important that as countries and various stakeholders, we need to reaffirm our commitment to invest in systems that support mothers and babies to ensure nurturing care and lactation. Next slide. So the urgent call to action, there is need to support the premature infant-mother pair survive and thrive to achieve their full potential. Thank you very much for listening to me.
Dr. Kiboneka, thank you so much for sharing your experience in both combining themes of nurturing care, the actual lactation support that is required, alternatives when that is needed through a milk bank, as well as the connection to KMC. That will be a common thread in this discussion as we turn to another setting in Latin America from Professor Adriana Montealegre. This is Dr. Adriana Montealegre Pomar. She is a Colombian pediatrician and neonatologist, a PhD candidate. She has a Master's of Science in Clinical Epidemiology, Pontificia Universidad Javeriana, Bogota. She's an associate professor at the Pediatrics Department and Faculty of Medicine. She's an epidemiologist and advisor on the Kangaroo Foundation research team and an expert contributor to Colombia's national clinical guidelines on kangaroo mother care. She collaborated on national guidelines for the premature infant care and child growth and development with the Ministry of Health, and is the co-author of peer-reviewed publications on KMC and care of premature low birth weight infants. So we will hear more of the details of how to integrate best lactation support with KMC practices. Thank you. Over to you, Dr. Adriana.
Thank you for the opportunity to present this important topic on kangaroo mother care and our efforts to support breastfeeding. Next slide, please. Well, how to reach exclusive breastfeeding? I have to remind you that the second main component of KMC is exclusive breastfeeding, if possible. Preterm or lover with newborns must be placed in skin-to-skin contact immediately after birth and then at the breast to provide immediate administration of colostrum. The kangaroo position stimulates breast milk production through the love hormone, the oxytocin. The mother can also express her milk while carrying her baby. Evidence shows an increase in volume, and this increase in volume in the NICU helps initiate and program long-term lactation early. For preterm babies, stimulation at the breast could be as early as 28 weeks gestational age and will continue until sucking becomes nutritive. The feeding strategies at hospital are gavage, plus sucking stimulation with mother's breast, oral drinking with syringe, dropper, cup, and finally, direct suction. Next slide, please. But KMC and breastfeeding needs that all medical staff must be trained in KMC and must be convinced on all the advantages of KMC. Medical staff must teach mothers about the importance of skin-to-skin contact for as long as possible during transportation to the NICU or to the kangaroo wards, and breastfeeding as the optimal nutrition. But if the medical staff is not convinced of these arguments, it's not possible to teach, to have a good teach about breastfeeding. The other way that is recommended to the women and child-friendly hospital strategy is avoiding introducing bottles and artificial nipples during hospitalization, because these tools can cause nipple confusion and lead to the abandonment of breastfeeding. Next slide, please. I'm going to show you different strategies, the different strategies that we have to feed babies. This is the syringe, the cup, or direct suction stimulation with the mother and orogastric tube. Finally, they could, next slide, please. Thank you. Next slide. Yeah, this is the other, and the next slide. Because I have to show you the correct position. This is lactation counseling, the Kangaroo Mother Care programs, ambulatory follow-up. We have a lot of babies with oxygen because in Bogota is a high altitude city. But with these babies, with ambulatory oxygen, we can reach successful breastfeeding with lactation counseling. Next slide, please. Well, okay. Thank you. The other slide, please. Thank you. In Colombia, thanks to the collaboration between the Kangaroo Foundation and the Ministry of Health, We had national KNC technical guidelines with a strong focus on nutrition. These guidelines help standardize KNC implementation across the country. Next slide, please. Well, as healthcare providers, we must remember that breastfeeding is more than just a nutritional process. This is the mother and child reunion with physical and emotional support. Next slide, please. Well, during the Kangaroo Mother Care follow-up, we have two phases. The phase number 1 is from hospital discharge until reaching term, 40 weeks gestational age. In this phase, the focus is on lactation counseling, the detection of oral dysfunctions and correction of mother posture and baby's position on latch. We, in the Kangaroo Mother Care initial phase, we have two daily weight monitoring until the growth rate is at least 15 grams per kilo per day. Then we monitorize the weight weekly until term and until reaching 2,500 grams, whichever occurs last. Next slide, please. These are some pictures. Excuse me, could you, I need the last slide. These pictures are some exercises that the staff teach mothers to improve breastfeeding. Next slide, please. Well, this is the right posture in kangaroo mother, in kangaroo position. The mother can kiss the head of the baby. This is a key recommendation for kangaroo position, and the right posture for mothers to avoid back pain, for example, and the right position for their babies. Next slide, please. Well, if adequate growth is not achieved, the first step is to use the mother's own hind milk to provide the supplementary caloric intake and to give intense lactation counseling before have a preterm formula. Next slide, please. Well, in the second phase of Kangaroo Mother Care programs follow-up, breastfeeding promotion could be reached thanks to the support of public policies. This is especially important for worker mothers. These public policies could be, can be maternity leave, extended maternity leave in the case of multiple pregnancies or premature births, and the installation of breastfeeding-friendly rooms in the workplace. Next slide, please. Well, I'm proud to show you these results. These are the results of more than 60,000 babies followed up in the Kangaroo Mother Care program from Colombia. At admission to the KMC programs, the percentage of exclusive breastfeeding is 57%, and at 40 weeks gestational age, 57.2%, and at 3 months, 56% of exclusive breastfeeding, and finally at 6 months corrected age is 44% of exclusive breastfeeding. We hope to improve our percentages, but I think that they are really good. Thank you for your attention.
Thank you so much for sharing your experience tying this to KMC, also showing videos and pictures of how vulnerable and small and how feeding directly at the breast is a journey. It takes time and effort and practice, and supporting lactation while the baby is building the ability to feed at the breast. What does it mean to support lactation and acknowledge the mom's needs through expression? So thank you so much for sharing that level of depth. I think I was fixing my own posture when you were teaching about posture as well. That was incredible. I want to move us quickly now to our last speaker before the Q&A. Ms. Ruby Kimondo will be sharing her personal story of a peer support program in practice in Kenya. She is the founder of Preemie Love. And so as the founder of Preemie Love Foundation, a national support network of mothers of preterm babies based in Nairobi, Kenya, she established a foundation in 2015, inspired by her own experience with preterm birth. A psychologist by profession and a mother of 4, 3 of whom were born prematurely, Ruby is a passionate advocate for stronger psychosocial support for families of preemies. Through Preemie Love, she has supported over 1,000 families across Kenya by fostering peer networks, organizing hospital outreach, and raising public awareness. While headquartered in Nairobi, the foundation actively reaches families in several other countries. Ruby is deeply committed to ensuring that every family with a preterm baby receives the care and support they need. She is driven by a desire to improve lives and create meaningful impact in her community. Over to you, Ruby.
Thank you so much, Kimberly. Really appreciate that introduction. Yeah, so good afternoon, everyone, and happy World Breastfeeding Week to all of you. If you hear some noise in my background, it's because I work in a university here, so there might be students walking in and out. So I'm deeply honored to be part of this global conversation today, and I'll be sharing insights on how peer support is transforming care for mothers of preterm babies, and how we can optimize its power to promote and sustain breastfeeding. So next slide, please. So to understand the power of peer support, we must first understand the emotional landscape of preterm birth. And in the next 2 slides, I'm just going to try and describe that. Welcoming a premature baby or welcoming a baby prematurely throws parents, especially mothers, into very unfamiliar grounds. And it's often an overwhelming experience. Many moms find themselves in the neonatal intensive care unit for the very first time. And of course, there's they experience a lot of fear and uncertainty in this space. So our role as mothers, when in the NICU, especially in the first time, becomes very passive, watching from the sidelines, waiting, there's a lot of waiting, and following instructions. So this experience creates a painful in-between state. I don't know, I've read about it. There's research that has been done about this, but I'm just not going to quote it here. But what I'm just going to say simply is, it puts you in a space where you're no longer an expectant mother, but you're also just not fully parenting. So this experience can deeply unsettle a mother's sense of identity and connection. Next slide, please. So these are some of the hidden struggles of the preterm birth experience. So it's not only just a medically complex experience, it's also just, again, a very isolating experience for the mother. Moms of preterm babies can feel very alienated because they go through a pregnancy and birth experience that most of their peers and community simply cannot relate to. So they also may lack information about prematurity and the intensive care that babies who are preterm go through once in hospital. So this gap in knowledge, combined with the trauma of a difficult pregnancy, it is traumatizing going through a difficult pregnancy like that, and even the early birth of the baby can have a very serious and psychological toll on the mother. So there's the disconnect in terms of the feeling of alienation, and then there's the disconnect in terms of information and knowledge, and this can lead to feelings of helplessness, guilt even, and inadequacy, loss of control, and particularly when mothers have very few avenues for support. So in this vulnerable state, the isolation can push mothers towards poor decisions, not because they are negligent, but out of desperation sometimes, or just misinformation. That's why even a simple act of reaching out, a word of comfort to a mother, can bring relief. It reminds them that they're not alone, and it gives them just enough courage to take on the difficult task or demanding task of caring for these tiny babies, these fragile babies, these medically vulnerable babies. Next slide, please. So this is where peer support becomes transformative because it offers both the emotional and practical help from someone who truly gets it, somebody who's been through it. So it creates a safe space where mothers, they can feel seen, they can feel heard, and held. So shared experience does breed empathy and hope, and it reduces that isolation that the mothers experience especially when they're in the NICU, and it helps the mothers to reclaim their voice and their strength. Next slide, please. So the Preemie Love model, we built a peer-led model grounded in mutual support, safety, just creating safe spaces and non-judgment in the groups that we have created. Since 2015, we've supported over 1,000 families across Kenya through mother-to-mother networks, through hospital visits, through community outreach, advocacy, education. Our approach is not about instruction. It's really just about walking alongside the mothers as peers, listening, holding space for them, just being present with them. And that's where they get a sense of safety, and that's where the healing begins, especially because they've gone through a lot of distress through the process of the difficult pregnancy. Next slide, please. So has it worked for us? Yes, I've seen time and time again what happens when one mother works alongside another mother. So it starts with the peer moms themselves. So the peer mom herself, she grows in confidence and purpose. She gets an enhanced self-esteem. And then the mothers who are supported, they report greater emotional well-being, they have more clarity in their decision-making, and they gain stronger social connections. So we started it in 2015, and those are many mothers until now. I've talked about over 1,000 families that we've impacted, and we've created very strong social connections to date. So their capacity to care, these are the moms who've been supported, including breastfeeding, expands. So it becomes a ripple effect. One empowered mother supports another, and the cycle continues. Next slide, please. So how can we use peer support as a tool for breastfeeding? So it's one of the most powerful areas where peer support makes a real difference is in breastfeeding, and I've seen this in practice. When a mother hears, I've been there and you can do this too, it changes everything. Peer support normalizes the struggles of feeding a preterm infant, which are often very different from what mothers expect. Most moms of preterm babies are dealing with a baby who won't wake up to feed. This is once you've been discharged from hospital and you've gone home, a baby who won't wake up to feed, who's feeding very slowly or very little, who'll gag or vomit during feeds, or the baby will get frustrated at times and even refuse the breast altogether. Adding to that is the mother's own challenges, painful nipples, low milk supply, the stress of expressing and how to store this expressed milk, questions on how often to top up once you've gone home, breastfeeding with a cup, how to use a cup, and then the fears about choking during cup feeding. I could list a whole number of things that are challenges for moms when it comes to breastfeeding, and especially moms of the small and sick newborns. So without guidance, these situations can feel overwhelming. But when peer mothers share how they manage similar hurdles, it becomes more achievable. Peer support brings about trust, it builds trust, it encourages confident lactation, and it extends that care beyond the hospital stay, because now mom is at home alone, but if she's connected to peers, she still gets care. So it gives the moms practical tools and the emotional reassurance they need to keep going. Next slide, please. So as we mark this important week, let's recognize that promoting breastfeeding, especially for the small and sick newborn, requires more than the clinical interventions. It requires empathy, connection, and sustainable peer networks like we have formed at Preemie Love. So let's invest in systems that center mothers, systems that blend clinical care with community-led support. So let's work with mothers, not just care for them. And thank you very much for your attention.
Ruby, that was just fantastic overview of the strength and power that empathetic support can provide. So mothers that have gone through this experience themselves, learned to express milk and feed their babies expressed milk, how they can sit alongside other mothers to show and care and remember the tears and the strength that is needed to get through such a strong and challenging season. Thank you for that background. So in all, we have heard all different perspectives, from the mother's experience to the clinical provision to the policy, what exists for this specific population, the small and sick newborn and their mother, and what we can be doing to support. So we'll be turning to Dr. Emily Njuguna, my own colleague, to help with the remaining Q&A time that we have. Emily is an incredible pediatrician and global health expert. She's the Africa lead for our maternal and newborn health at PATH and the nutrition lead for the Africa Neonatal Association. She advocates for better nutrition policies for infants and vulnerable newborns in resource-limited settings. Over to you, Emily.
Thank you so much, Kimberly. Good morning, good afternoon to you all colleagues from wherever you're joining us. We are really excited about this webinar, and I'm even more excited to share some of the questions that you have added in the chat. So I'll just be looking through your questions and asking them to the relevant speakers from today. And if we don't go through your questions, please don't feel discouraged. We will give you some information about which email address you could use to share your questions, and our team will be on hand to answer them. So I will start with just one question to Dr. Adriana Montealegre and Ruby with regard to your experience working with moms of small and sick newborns. We know that small and sick newborns, or rather delivering a small and sick newborn, can be very traumatic. And so in your experience, beyond the support that you need to help your baby to grow well, what have you seen moms needing most to thrive in this journey? And then this is to Ruby. Perhaps you could start with Ruby and then Dr. Montealegre.
Okay, I think that emotional support and also hands-on since hospitalization is very important for these tiny babies. So hands-off and emotional support, I think provided by health team are the most important things for these mothers. The experience in the training of breastfeeding is an experience in the day by day since delivery and since NICU. That's why it's very important to have open units for parents. Parents in the KNC program, in the ambulatory follow-up, are less stressed if they have the opportunity in the NICU to take care of their babies 24 hours. So I think that it's very, very important, the open NICUs for the follow-up.
Thank you, Dr. Adriana. Ruby, just very briefly in 1 minute or so.
Yes, so I think bringing moms out of that passive role is very important. They need to feel very actively involved in the care of their babies. And especially, and I'm referring to public healthcare systems where we have many mothers and many babies. So most of the time, it's not very easy to achieve that. But I think that just educating these moms, looping them in what's going on with their babies, medication they're getting, interventions they're being taken through, I think that would be very important and would really help the mothers.
Thank you so much, Ruby. Unfortunately, we've come to the end of our time on this webinar. Thank you to all our incredible speakers and all the participants, especially those who are dialing in from different time zones across the globe. Today's conversation has really reminded us that while our contexts are different, we've had from Asia, we've had from Africa and other areas, Though our contexts are different, our commitment to feeding the small and sick newborn should unite us. Today's discussion, as a reminder, emphasized 3 things. First, that human milk is medicine and it is critical for the survival and thriving of the small and sick newborn. And secondly, that essential newborn care for the small and sick newborn must be integrated and prioritized across all health systems. And third, that mothers are not just recipients of care, they are active agents of change and they must be involved right from the start. So let's take inspiration, the tools and the science that we've had today, and use them to build more nurturing and equitable systems for every newborn and every mom. As a reminder, we'll be sharing this recording soon. And until next time, let's keep championing for the support of the small and sick newborns. We have upcoming webinars that you can see on the screen. Please look out for that. But until next time, thank you all and merci beaucoup.
Thank you all.